Everybody to today's Cardiac MR Journal Club that for the time being had been transformed into a Cardiac COVID Journal Club because of obvious reasons. And I welcome you today from Montreal. Behind me, that's a virtual image, but that's basically one of the icons of Montreal. It's the Five Roses flower factory, which is a kind of an industrial art project or art piece here in Montreal. Okay, so I'll jump right into, and first of all, I welcome Enrico Ammirati, who will later on, he wrote an editorial to one of the papers we discussed today, and he will then report on his own experience with cardiac COVID in Italy. So let me start with a case series that was published in the New England Journal called ST segment elevation in patients with COVID-19. So in these days, papers not always are of that high quality, but because of the urgency, they are often still accepted and published, and then for good reasons, because they provide some preliminary information on a highly dynamic topic such as COVID-19. So what they did here, and the first author is Dr. Bangalore, and this is mainly experience from New York. So here you see the co-authors. What they put together a series of a total of 18 patients with COVID-19 and ST segment elevation, and they looked at what were the risk factors and what was happening to those. And the paper will be, as all the others we discussed today, open for download for the members. In brief, what they found is in these 18 patients that 10 of these 18 had non-coronary and 8 had myocardial infarction. So the 8 had ischemic and 10 had non-ischemic. That confirms previous, let's say, previous findings that patients may have non-ischemic injury caused by inflammation, either directly by the virus or in the second phase by the so-called cytokine storm, where the secondary inflammatory response then triggers a severe reaction in tissue that may damage then the lungs, leading to the respiratory distress syndrome that is still considered the most important clinical feature of severe COVID-19, but also then the heart. And I'm not going through the details of the characteristics of these patients, but important that equally they were affected by cardiac arrest. And those with non-coronary injury did slightly worse with respect to shock and cough, but given the small sample size, this is statistically not significant. But the outcome was definitely not better in those with non-coronary tissue. So these are the findings here, and the important takeaway points were that 10 of these 18 patients had the ST elevation right at the beginning, whereas 8 developed it during the hospitalization, and median 6 days, which means that those with non-coronary, so those presenting initially, they may have already been in a somewhat more severe stage of the disease, but it also indicates that those 8 patients that initially did not have ST elevation and then developed it, that this was basically the result of the second phase, the more severe inflammatory response. So interestingly, the 36 patients, 36% of patients with a focal ST segment elevation, so 5 only, all it's a small sample size, let's keep that in mind, had a normal ejection fraction, and that's also important. So an abnormal ejection fraction does not rule out cardiac COVID. We know that from myocarditis that, in fact, in many case series or publications, the majority of patients with myocarditis, in necrotizing myocarditis, had normal LV function. So that is important for the work of these patients. And then also important, only 9 patients of these 18 had a coronary angiography, of which 6 had obstructive disease, and 5 of them had a PCI, whereas the rest did not have coronary explanation. So again, we definitely have to deal with at least 1/3, if not half, of the patients, or even more, have a non-ischemic injury pointing to myocarditis as the main complication in these. So that's what could be, yeah, maybe as a side note, all 18 patients had an elevated D-dimer, for whatever that means. Of course, they have a pulmonary problem, so that may be just a bystander, but it may be that all of these with severe disease also had their lungs affected, and that, of course, would explain the increased D-dimer. So that was that case series. Then another brief paper published in the British Medical Journal on the NICE guidelines that were put out. So NICE is the National Institute for Health and Care Excellence, a very well run body putting out guidelines based on evidence. And what they did, that is in London, what they did, they put together the evidence and then made a very brief recommendation. And the key points here were that cardiologists should be involved, and they emphasized that acute myocardial injury and its complication could emerge at any stage of the COVID-19 infection, and therefore they recommend testing troponin and BNP, or end-terminal pro-BNP, and ECG to monitor these patients because of the severe complications and also therapeutic consequences of that. So cardiologists should be involved whenever there is a clear diagnosis of myocardial injury. And those of you who already were present at the previous journal clubs, I had already suggested a workflow proposal where cardiac MR could be involved for those centers who have access to cardiac MR. The moment you have myocardial injury verified by troponin, it would be important to differentiate ischemic from non-ischemic, and also look at the severity of the tissue abnormalities. And this is what you can do with MR fairly quickly, without the use of toxic contrast agents, and even if you want, without the use of any contrast agents at all. If you're interested in that, either send us an email or go back to one of the previous journal clubs. They're actually the first on COVID, where this was also then posted. So whenever there's a suspicion of myocardial injury, then further workup by cardiologists is recommended. So that was the paper by Editorial representing the NICE guidelines. Another very long paper published in JACC addresses the role of the critical care cardiologist. And I will not go into too much detail, but this is an extensive paper called Disruptive Modifications to Cardiac Critical Care Delivery During COVID-19 Pandemic and International Perspective. So this is for people who are in intensive care or cardiologists being asked to provide advice. So this is a nice resource on what you could do to modify the care to be more efficient in COVID-19. Okay, so then the last paper I wanted to directly address is also, it's more a case series. It's about suspected myocardial injury in patients with COVID-19, evidence from the frontline clinical observation in Wuhan, published by Deng and others. And so they basically just looked prospectively what happens in patients with myocardial injury. So they enrolled a total of 112 patients, and they found that myocardial injury was found in 12.5% that were consistent with myocarditis. So that is basically confirming, although their numbers are smaller, and I'll get back to that why. So this was a retrospective study. So sorry, they were prospective enrolled, but it was a retrospective analysis. And they classified these people as mild, moderate, severe, or critical. And then concerning myocarditis, they defined that they had a very strict definition of myocarditis. That was a triple elevation in cardiac troponin I, plus abnormalities on echo or ECG. Echo, they had an ejection fraction of less than 50%, or segmental wall motion abnormalities. Then they also looked for signs of hypertension, but what it means is that they may have missed myocarditis with completely normal LV function and a normal ECG, even though they had an increased troponin. So I think that's a limitation of the paper that may explain why only 12% of their sample had myocarditis. So it was a very strict definition of myocarditis. So when they looked at the outcome, the composite endpoint they looked at was admission to ICU or ventilation or ECMO or death. And of these 112 patients, they had the usual, what we already know, the cardiovascular risk factors are also apparently risk factors for cardiac COVID. And so they had, 2/3 of them had actually chest pain or tightness, and more than half of them have had shortness of breath. And when they looked at the severity of groups, they also found that older age and so there's nothing, and obesity were risk factors. So there's nothing very special here. But if we look at the more signs of myocarditis, what they saw that there were more patients in the severe group had pericardial effusion. So this may be a sign, so it's 28 versus 7%. Maybe a sign for more severe disease, probably not that, let's say, specific. Then they also had signs of pulmonary hypertension. And so 12.5%, as I said, had, based on their strict definition, myocarditis. And 9% had abnormalities on echo, and just 2 had echocardiogram abnormalities. And they removed 6 patients, so, but that's not. So when they looked at the outcome, they saw that, this is the characteristics. There were some differences. So if they had myocarditis, they were more likely to have cough, shortness of breath, chest pain. So all these symptoms were more likely than in others. They also looked at the coexisting conditions, but expectedly for myocarditis, these were not as predictive as we see it in the usual COVID-19 papers. They looked at now the patients who died from COVID-19, and there is not really a very strong pattern that could be seen. So the LV ejection fraction was between 40 and 70, so that was not really helpful. So the regular markers like echo and ECG may not be helpful. So that points to the fact that these patients have to be taken seriously when monitoring the patients, and the clinical deterioration probably is still the most sensitive one. So if patients develop severe shortness of breath and have an increased troponin, then it's quite likely that they may have a myocardial involvement, and then unfortunately echo may not be enough. Again, I would stress the point here, if people have access to a cardiac MR, I think it should be done, especially because with a cardiac MR, you can also just add some, let's say, some slices through the lungs and also look at the pulmonary involvement. So they consider the cardiac markers as warning signs, and their conclusion, which I do not totally concur with, is that myocardial injury is more likely to related to systemic consequences rather than direct damage by the 2019 novel coronavirus. But because they do not have biopsy or CMR, we do not exactly know how many of them actually had had disease. So the bottom line for this paper is there are a couple of limitations. It is still important because it's from the early experience in Wuhan. Bottom line here is that it confirms that patients with clinical evidence for myocardial injury have to be monitored closely. Troponin should be taken, and once the troponin is high, they may have ischemic or non-ischemic injury, both putting them into high-risk groups. And then I would add in patients with where you have access to cardiac MRI, you should do that. Okay, so before I hand over to Enrico, just a brief question out there. So if you have questions, feel free to put them into the chat box, or just unmute yourself and speak up. So there's a question from Attila Tot from Budapest. It would be really interesting to know the amount of myocardial damage in case of all those marked viral infections that force the patients to bed for a significant, for example, for a significant flu. I guess some amount of myocardial injury could be recorded when you have widespread muscle ache, barely able to reach the sofa, and it takes a separate project to turn on the TV using the remote. I bet there would be some myocardial injury. I totally agree with that. I think that a lot of the systemic symptoms people experience, the weakness, the fatigue, in many of these patients points to a myocardial involvement that we're just typically not necessarily aware of. We know that ECG changes happen in about 50% of patients with a regular flu. We know that if we look carefully that 8% of the general population has, in autopsy, has findings for some non-ischemic scars in the myocardium. So myocarditis is still underappreciated, and this example from Wuhan is a good example because they just looked at a fairly strict definition with biomarkers, LV dysfunction or ECG abnormalities. And while I totally understand why they did that, but that may mean in this population we may miss a few of them. So this paper was accompanied by an editorial by Enrico Ammirati and DaoWen Wang, also in the International Journal of Cardiology, and the editorial was entitled SARS-CoV-2 Inflames the Heart, the Importance of Awareness of Myocardial Injury in COVID-19 patients. So I would now stop sharing my screen and ask Enrico, again, thank you for joining, to basically give your view of the paper and also report on some other experience. Enrico.
Thank you again for this kind invitation. It's a pleasure to join the webinar, and I'm going to share the my screen, if I'm able to do that.
So there's this green button on the bottom of one of the windows. It just says share screen.
Share participants. Or maybe it's, let me check. Exit full screen.
Yeah, Zoom sometimes has two windows, and in one of them, typically where you also see the participants, there's this kind of green in the center. So it says participants, chat, share screen, and then.
Okay, perfect. Okay, I think that is this one.
Yeah, it's this
okay.
one. Yeah. Now, yes. Now our paper.
Okay. So I have. I've prepared a few slides to summarize. I work in Milano at the Niguarda Hospital, and in my view, the most important point of this paper is that it is the first large reports on echo data in these patients, because we have 112 echo data, and comparing with the two most famous series on cardiac injury, we have the paper by Guo and the other paper by Shi that are both published in JAMA Cardiology, where they presented the percentage of cardiac injury in patients admitted with the COVID-19, but in these two important studies, they did not report any echocardiographic data. And if we refer to this manuscript, we see that the mortality rate associated with the cardiac injury are between 23% to 50%, 51% of cases. So it's an important marker of risk for these patients. So in my view, and as it is recommended by the NICE guidelines, troponin must be, or in particular high sensitivity troponin must be a marker to be known since admission of these patients. The proportion of patients with myocardial injury on admission can vary a lot, and that's mainly based on the clinical condition at presentation of these patients. So if we have a series where we have a higher proportion of mild cases, we have a lower proportion of patients with the cardiac injury. If we look at patients with a higher prevalence of critically ill or severe patients, of course, we see that we have a higher proportion of cardiac injury. Another point that I noticed writing my editorial was the uncommon high proportion of reported chest pain and chest tightness. That could be also a specific sign related to pneumonia. In fact, we know that this pneumonia is mainly with the peripheral lesion, so it could be that chest pain or tightness can be also related to pneumonia. Really, this proportion is uncommon comparing with previous studies. Then another point that we know is that the echo data about left ventricular ejection fraction says to us that in most of cases ejection fraction is preserved with a median of left ventricular ejection fraction between 55 and 60% on echo. There is a paper in circulation in 2003 where they analyze echocardiographic data in patients with SARS. And also in that paper, the median left ventricular ejection fraction was within normal range. So what we know is that there is a problem in the heart, but it's not. We do not find a depressed ejection fraction in most of cases. And again, when we look at the patients in this manuscript, where they have a threefold increase of troponin plus echo abnormalities, that we have seen that echo abnormality can be also just pericardial effusion or wall motion abnormalities. We found that just 10 patients have these abnormalities, and only 2 patients have all abnormalities, laboratory abnormalities, echo and ECG abnormalities. And it's in line to me also with what we can find in myocarditis with the preserved ejection fraction. They are quite common to have a completely normal ejection fraction with by far more higher level of troponin. In fact, another point that I would highlight is that the increase of troponin is not so high as we expect with normal acute myocarditis we are used to look at. In fact, fact, maybe we have a 1,000 of troponin increase, while in most of these papers, the increase of troponin is not so high. And this is just to resume some of the data about rate of cardiac injury. And in the first, in one of the first paper in JAMA, for instance, the paper by Wang of 138 patients with COVID-19, the prevalence of cardiac injury on admission was just 7.7%. And we are working on with Dr. Wang in Wuhan about the prevalence of cardiac injury, and in particular in critically ill patients. We have a submitted paper on that, and the prevalence in critically ill patients, that means in patients admitted in the intensive care unit, the prevalence of cardiac injury is around 38%. I'm just focusing on 3 case reports on acute myocarditis, because in my view we have to check how is the real patient. Because when we look just at the laboratory test, we do not have a specific idea of the characteristic of this patient with suspected myocarditis. So what we know is that in most of cases, ECG and echocardiogram are often normal on admission. So in my view, it's not needed. So you do not have to call a cardiologist just to expose him to perform an exam that in most of cases is completely normal. So troponin can be enough. Second point, there are a group of patients where the cardiac symptoms prevail. This is the case of this 53-year-old woman that we described with the colleagues from another hospital here in Lombardy, from the group of Marco Metra in Brescia. The first author is Inciardi, is a case report published in JAMA Cardiology. And in this case, that I invite you to read if you have time. In this case, this woman presented with chest pain without significant lung involvement. So she had a previous fever and cough. So that led to admit this patient in the cardiology ward. Then they performed the swab, and the swab was positive. But before the result of the swab, the patient underwent cardiac magnetic resonance imaging scan. And for instance, in Milano, we have closed the cardiac magnetic resonance imaging facility due to the outbreak. Of course, it depends on the risk related to the in-hospital outbreak. But at the beginning of this outbreak in Lombardy, the time to have a result from the swab could take more than 1 hour, 1 day. Again, about this case, we see that this is the cardiac magnetic resonance, and you see that stir sequences are clearly positive, and this patient had also a significant decrease of left ventricle ejection fraction. The ejection fraction was 35%, and she needed dobutamine. We treated this woman with troponin was increased, but not so much. And we treated this patient with, at that time, with the Caletra and hydroxychloroquine and with methylprednisolone, around 1 milligram per kilogram for 3 days. And the patient was weaned by dobutamine after a few days, and she was discharged. the main theory about the cardiac injury is related to non-specific cytokine-mediated cardiotoxicity. And in the next two cases, I can show you why we think that that could the main mechanism of disease. This is another very interesting case report from Milano, from the San Raffaele Hospital, and from the colleagues of Simone Sala and Giovanni Peretto, and the pathological specimen were analyzed in Padova by Cristina Basso, so a very famous cardiac pathologist. Again, this woman presenting, complaining mainly chest pain, not dyspnea, but she had severe hypoxia. The swab were positive. In this case, again, you see that the troponin was increased, but not so much. I expect every time I see a depression of the left ventricle ejection fraction, generally I expect high level of troponin. It is not always true. Of course, we have giant cell myocarditis, we have lupic myocarditis where troponin is not so elevated and we have a patient in cardiogenic shock. But in most of cases, with a reduction like that of left ventricle ejection fraction, I expect a higher level of troponin. Cardiac magnetic resonance imaging was performed after 7 days. And again, you see that stir sequence were clearly positive, but there was no LG presence. This is quite uncommon in my view, because I would expect at least a diffuse LG as expression of edema, but at least based on these images, we see that LG is absent. And again, mapping was in favor of inflammation. In particular, T2 mapping was 62 and it was increased. And again, they were also able to perform endomyocardial biopsy, and the biopsy was performed the same day of the cardiac magnetic resonance. And they showed that there was some lymphocytes somewhere in the myocardium. Probably the patient reached the diagnosis of myocarditis, but not based on Dallas criteria, mainly based on the cellular count of lymphocytes. But we do not have a clear inflammatory infiltrates. And another point was that the viral search in the myocardium was negative. Here is the treatment, and the patient recovered without specific immunosuppressive therapy. The other point that they remarked was that this case, in particular the abnormalities of the wall motion, resembled a reverse Takotsubo. We do not have the clear images. In my view, this is it could be just a suspected myocarditis with maybe the endomyocardial biopsy was negative. The important final result was the patient again was discharged alive. Then we have this super interesting paper from Pavia, another town in Lombardy, by Guido Tavazzi, and the senior author is Eloise Arbustina, another known cardiac pathologist. And in this case, we have a man presenting with a real cardiogenic shock. And in this case, this man presented also severe bilateral lung opacities and consolidation. The swab, nasopharyngeal swab, was positive for SARS coronavirus 2. And the initial echocardiogram demonstrated a severely depressed ejection fraction that was 34%, and the left ventricle and diastolic diameter was 56, so mildly dilated. In 1 day, the patient decreased to 25% of ejection fraction and developed a clear cardiogenic shock. Troponin T was severely elevated, more than 4,000, as I expect in a patient like that. C-reactive protein was high, 52, and also lactates, sign of cardiogenic shock, were lactates were increased. The patient was supported on ECMO plus intra-aortic balloon pump. They perform endomyocardial biopsy. Of course, in this patient, it was not possible to perform a cardiac magnetic resonance. I believe that another point with unstable patient or with intubated patient can be very challenging to perform, of course, a cardiac magnetic resonance. So in particular in critically ill patients, I do not suggest to perform a cardiac magnetic resonance to investigate a cardiac injury, because you have a lot of, even if you are able to do that, you have a lot of artifacts, in my view, due to the clinical condition of the patient. And they perform a coronary angiography. There was no sign of coronary artery disease, but the important point is that they perform also electronic microscopy. And they found...
Enrico, sorry to disturb, please speed up because we're running over time.
Okay.
We're already 6 minutes over time, so...
I'm sorry.
Make it as short as possible. Thank you.
Okay. The important point is that they did not find any viral particles in the cardiomyocytes, but there were viral particles in the interstitial macrophages. So, and again, we do not have any evidence of a clear inflammatory infiltrates. Also in this case, we have sparse macrophages in the heart, also in this case, but not infiltrates. And we do not have evidence of virus in the cardiomyocytes. So it seems again that it's not a direct injury of the virus against the cardiomyocytes, at least based on these two well-characterized cases. Okay, I'm sorry for this delay.
No, thank you. I'm sorry, but we have to be very respectful of the time of the people. Okay, thank you very much especially for going through these cases. So the bottom line here is, if I may say so, and if we take just one more minute, and feel free for those who have questions to post them. So what we see indeed is edema we have only a few cases so far, but edema seems to be very important, and not necessarily the focal necrosis, as you pointed out, as we see in regular myocarditis. And then this case here may suggest that there's indeed not a lot of direct viral injury. So one aspect that has not been studied yet fully, and I actually have to thank Javad Rafi from my group for pointing out to that, and it's indeed true that the ACE2 receptor is involved in regulating vascular permeability. So if COVID, what it does, basically takes ownership of all these ACE2 inhibitors, then vascular permeability may go up. And we know that ACE2 is specifically prevalent in the lungs, in the heart, also in the intestinal system, in the testicles and the kidneys, but most important in the lungs and the heart. So that may explain why we see a severe inflammatory response, which may be largely due to the vascular permeability edema that we see in these cases where MR has been done, but also may explain this funny gel-like exudate we have, or transudate, we don't know yet for sure, in the lungs. So that is an interesting aspect, and I hope we will have more data coming in from MR showing whether that's true, that edema is just a key component of cardiac COVID.
The problem is that viremia is less than 1%, at least in a JAMA paper where they analyze in more than 300 patients, where they got the blood samples. And another point, there is another paper in Science from Germany that they did not find any virus in the blood. So it could be very important, at least at the level of in the interface of the alveoli, or in the gastrointestinal tract, maybe this interaction and with the ACE2, but we do not know in the heart, because of course it can be that in some patients there is viremia, and so they can act at that level, but in patients without viremia, it's difficult to figure out how the virus can reach the heart without passing through the blood.
Yeah. Yeah. Okay, so thank you so much, Enrico, and thanks everybody for joining. I think there is more to learn, and we will hopefully get data from studies done with cardiac MR in the near future. We're also running one here in Montreal at McGill, together with Cedars-Sinai Hospital, where we try to find out what the phenotype of cardiac COVID is. I want to point out before I leave you, our next journal club will be end of May, May 27, but May 13 is the JCMR Journal Club. So that is these are the papers from the Journal for Cardiovascular Magnetic Resonance. I just posted the link in the chat box. That will happen on May 13. Raymond Kwong will present a paper there. And there also, for those interested, I also want to say today is also at 11 o'clock, there's an SCMR webinar on physics, but only for those who are interested in that part. So with that said, Enrico, mille grazie. Thank you very much for joining, and all the best for you. How do you see the final question? How do you see the situation in HLA evolving now? It looks, the numbers look that we're getting better, but still the numbers are high. So what is your?
I'm really worried because I'm really worried about the end of the lockdown.
Yeah, yeah. So that's what we all do not know. Will there be a giant second wave? And then what happens in fall? Do we have to expect a third one then? So yes, COVID-19 is not over, but on the other hand, the lockdowns also have significant implications on a societal level. Many patients do not get their care, so they die from other causes at home because they are afraid of going to the hospital. So we're all living through a very, very